Hello, good afternoon, distinguished healthcare practitioners. My name is Timothy Okeje, and welcome to our webinar that looks at feeding principle in early and late preterm infants. We welcome you all to FrieslandCampina Institute. Just a disclaimer as we start this webinar. At FrieslandCampina, this is one thing we stand for. Breastfeeding is the best nutrition for healthy growth and development of babies. And as an institute, we support and promote exclusive breastfeeding for the first 6 months, which is the optimal way of feeding infants. And thereafter, infants should receive complementary feeding with continued breastfeeding up to 2 years or beyond. Also, mothers should receive guidance on proper maternal nutrition in order to help sustain an adequate supply and quality of breast milk. Of course, unnecessary introduction of bottle feeding partially or fully or of other complementary food and drinks may have a negative impact on breastfeeding, which may be irreversible. And that is why mothers should consult their doctors and consider the social and financial implications before deciding to use breast milk substitute, or if they have difficulty breastfeeding, usage and preparation, also storage instruction of breast milk substitute or of other complementary food and drink should be followed carefully, as improper or unnecessary use may pose a health hazard. So, distinguished healthcare practitioners, I welcome you to this presentation as I introduce our distinguished speakers. Just for the record, this webinar is being recorded, and during this webinar, you may have the opportunity to ask questions, especially using the chat box, the Q&A sections. Just a quick overview about FrieslandCampina Institute. FrieslandCampina Institute is a platform that shares knowledge, scientific knowledge, where we stimulate scientific articles, learning program, and brochure. Also, FrieslandCampina Institute is located currently in about 30 countries. Nigeria is one of those countries. FrieslandCampina Institute is founded in the year 2001 and has an annual interaction of approximately 3 million with healthcare professionals. And of course, one of the key things we do is knowledge sharing by disseminating scientific information on the role of dairy in our diet, and we believe we can improve on the nutritional status of people. And that is why in this particular institute, we collaborate with healthcare practitioners, and that is why we have this webinar for us to also collaborate and more. To take us further in this presentation, I would like to introduce our first moderator in person of Professor Adebola Emmanuel Orimadegun. Professor Orimadegun is a distinguished pediatrician and a clinical researcher who currently serves as the director at the Institute of Child Health at University of Ibadan. And he is also a honorary consultant to the University College Hospital Ibadan. Also, Professor Orimadegun has over 2 decades of experience in clinical practice, teaching and mentoring. He has shaped the career of many upcoming medical professionals and researchers. As a recipient of numerous awards, which include the European and Developing Country Trial Partnership Scholarship, and also doctoral fellowship of William and Flora Hellwaite Foundation, Professor Orimadegun is a testament to the impact of interdisciplinary collaborative research in addressing complex health challenges. His leadership is in various research projects and clinical trials, notably those addressing neonatal care and nutritional intervention, align closely with the thematic focus of this webinar, which promise to be insightful in contribution. And that is why distinguished healthcare practitioners permit me to welcome Professor Adebola Emmanuel Orimadegun. Prof, you're welcome.
Thank you very much. Dear esteemed colleagues, respected panelists, distinguished guests, ladies and gentlemen, I would like to say it's a great honor and profound sense of responsibility that I welcome you all to this highly anticipated webinar titled Feeding Principles in Early and Late Preterm Infants in Nigerian Perspective. As we gather here virtually, yet connected by our shared commitment, we stand at the confluence of traditional wisdom and modern science. We are ready to explore, to debate, and to enrich our understanding of neonatal care in the context of our beloved country, Nigeria. The care of preterm infants presents one of the most delicate and crucial aspects of medical practices. It is a field where precision meets compassion. It is a field where evidence-based practice intertwines with the reality of clinical situation, and where every small decision you make can significantly impact on the life of infants. In Nigeria, the challenges are even compounded by diverse socioeconomic factors, cultural beliefs, and healthcare infrastructural constraints, making our discourse today not just relevant, but very crucial. Our focus on the feeding principle for early and late preterm is more than just a discussion on nutrition. It will be about laying a foundation for a healthier generation. It will imply understanding the intricate balance of nutrients necessary for their growth and the timing and method of feeding that align with our unique Nigerian context. This topic touches on the very essence of life and survival, bearing implications not only for the immediate health of the infant, but also for their long-term development and well-being. We are therefore privileged today to have with us a panel of distinguished experts who will bring with them wealth of knowledge, experience, insight into neonatal care, nutrition, and pediatric health management in Nigeria. Their dedication to this field and commitment to improving outcome of preterm infants in Nigeria and beyond is both inspiring and humbling. Therefore, as we embark on this intellectual journey, I urge you all participants to engage with open minds, raise questions critically, and collaborate freely. The exchange of knowledge is the most potent tool we have in our collective endeavor to improve healthcare outcomes. Let us therefore harness the power of this gathering to not only address the challenges, but also to spotlight innovative solutions and best practices that can be adapted and adopted across settings in Nigeria. In closing, I wish to express my deepest appreciation to all of you for your presence and for your active participation. The path to better healthcare is a shared journey, and each one of you will need to play an indispensable role in it. Together, let us forge ahead with optimism, guided by science, driven by compassion, and united in our goal of ensuring the best start in life for every Nigerian child. Thank you. I look forward to a fruitful and enlightening discussion. You are welcome. At this junction, I would like to hand over the moderation to Professor Kenechukwu K. Ilo. Professor Kenechukwu K. Ilo obtained his MBBS degree from the College of Medicine, University of Port Harcourt, a pediatrician and a fellow of the National Postgraduate Medical College of Nigeria and West African College of Physicians. He's a professor of pediatrics at the University of Nigeria and a consultant pediatrician and neonatologist at the University of Nigerian Teaching Hospital, Ituku, Uzala. Professor Ilo is committed towards excellent care in the field of neonatal care, pediatrics, retrovirology, and general pediatrics. He has published over 60 articles in peer-reviewed journals, both locally and internationally. He's a member of several associations, including Nigerian Society of Neonatal Medicine, NISO, where he once served as the secretary and presently Southeast Zonal Coordinator. He has also contributed to the development of guidelines and training manuals, including the National Comprehensive Guideline for Neonatal Care. Professor Ilo is also a senior priest in the Anglican Communion. Ladies and gentlemen, let me welcome Professor Ilo to continue the moderation. Thank you.
Thank you, Prof, for that kind introduction. And I want to say good afternoon to distinguished healthcare professionals that have joined in this webinar this afternoon, both within Nigeria and outside Nigeria. And this afternoon, we'll be taking on very, very important topics. And we have two distinguished presenters that will take us through these topics that we have this afternoon. The first presenter, who is Professor Chris van der Acker, will be taking us through the principles of feeding early and preterm infants, focus on enteral nutrition. It's my honor and pleasure to introduce Dr. Chris, who is a pediatrician and a neonatologist that is working at Emma Children's Hospital, Amsterdam, UMC in the Netherlands. His clinical and research interests are mainly within the field of neonatal nutrition and gastroenterology. He is an active member of European Society of Pediatric Gastroenterology, Hepatology and Nutrition, ESPGHAN, where he was one of the main authors of several recent ESPGHAN position papers and guidelines. These include recommendations on prenatal nutrition, enteral nutrition, and probiotics for the preterm infants. You can agree with me that Chris is an appropriate person to take us through the first presentation. Please, let's welcome Dr. Chris as he takes the next 25 minutes for the next presentation. Dr. Chris, over.
Thank you for this very kind introduction and of course, honorable invitation to present some slides with a focus on the, I got the invitation to participate in the ESPGHAN position paper on neonatal enteral nutrition, and then, of course, today's invitation to present some of the highlights of this this paper in which I was one of the authors. I'm happy to take you along in this 25 minutes. Of course, this is way too fast to provide you all the details of our position paper, but let's give it a try. And I'm happy to take also any questions in the Q&A afterwards. These are my disclosures. I do not have any preference for any product or brand in types with regard of nutrition, except, of course, I always recommend mother's own milk because I think that's always the best. So, as said, today's talk will mainly be on the our position paper we wrote 1.5 years ago. It was published in the Journal of Pediatric Gastroenterology and Nutrition and our lead author is Professor Nick Ambleton. It's an open access paper, so you can easily download it and reach much more of all things that I can say to you today. But if you don't want to read the whole paper, I can also recommend you to do this e-learning, which is available for free. It's a e-learning based upon the paper I just discussed, and it's a very interactive way of improving your knowledge on neonatal nutrition. It's a web of an e-learning of 4 times 3 hours, and it will definitely help your knowledge. And it's fantastic that it's also available for free. So I will also show this QR at the end of my presentation, so then you still have the ability to take a look, and I will also afterwards I will share the link of this e-learning in the Q&A. So to start, some background first. I think many of you are aware that, of course, preterm infants, but of course also the fetus, while it is still intrauterine growth at a very fast growth rate, especially the brain, of course, is very important. And the fetus growth, approximately 15 to 20 grams per kilogram per day. So that can also be translated in 1.5 to 2% per day of body growth. And that's the thing we want to replicate if an infant is born preterm. However, you may also know that on many neonatal intensive care units, growth faltering and malnutrition is seen very often, unfortunately. And that's especially problematic because preterm infants, they don't have any, or they hardly have any reserves, while, as I said, they have high needs. Simultaneously, we know that there are actually strong associations between intake and, of course, growth and body composition, but also on other outcomes, such as metabolic outcomes. So the vulnerability, for example, to have cardiovascular disease in later life, it can be influenced by early nutritional intake during early life, but also, of course, neurocognitive outcomes during later life can be influenced by nutritional intake. And I will come to talk about that later. So that's why it's always good to have good guidelines for neonatal nutrition, but simultaneously there's always, of course, many challenges to do so. As you are aware, neonates can form a heterogeneous population. We may have to care for a wide range of preterm infants. In our NICU in the Netherlands, we sometimes have infants of only approximately half a kilo, but also, of course, infants of 1,600 grams as an example, while they both have to fit in the same guidelines. Simultaneously, infants can be intrauterine growth restricted, or they can be appropriate for gestational age and body size. And of course, there are various phases in which an infant is on a neonatal intensive care unit. Sometimes the infant is relatively stable and can grow stably, but unfortunately, infants may get critically ill, for example, of a sepsis or a necrotizing enterocolitis, and then you cannot expect the infant to grow as well and also not to give proper nutrition that you would want to give. Also, when forming guidelines, you have to look at the evidence. Then the problem is, what are proper clinical endpoints? We do not even know what optimal growth may be, because we also don't want to promote obesity, for example. So you don't want to grow too fast, and you want to have a good body composition with sufficient muscle or lean mass and not so much a lipid mass. When we look at the brain, that's mainly our golden standard, there's another problem because it's very difficult to measure proper brain development, especially on the short term. Then when we're talking about nutrition, as said, I always recommend human milk, but human milk is simultaneously very variable. So if you want to make recommendations on the amounts, on the nutrients, human milk is not a solid single fluid. There are many differences between the one batch of human milk and the other. For example, it is known that the protein content in human milk decreases over the weeks after birth, whereas in guidelines we like to calculate with averages, but in fact these are wide ranges. Then if we look at formula products or artificial products, in all the countries, there are various or different products on the market. So yeah, we can recommend something, but if it's not on the market, then it's not a good recommendation, of course. So let's start with some guidelines. I've divided this presentation in various chapters. That are also the chapters of the guideline. And so each topic has some statements. And for further reading, I recommend you to the paper in ESPGHAN, or as said, the e-learning that is available for free. What we recommend with fluid requirements, it's not so surprising, but one of the statements is that most preterm infants require a fluid intake of approximately 150 to 180 ml per kilogram per day. It is not in the first day of life, of course, but after a week or so after birth, these are the requirements. But in individual cases, if the infant tolerates it well, or maybe not growing too well, then you can increase the amount of enteral fluid intake up to 200 ml per kilogram per day with milk, if it tolerates it. Then the chapter on energy. These are the some of the statements. And by the way, on the right side, I also stated if what the change is in comparison to the previous guidelines that we made with ESPGHAN. So in fact, there's an increase in the recommended energy intake for most healthy growing preterm infants. And nowadays we recommend to achieve an intake of approximately 15 to 140 kilocalories per kilogram per day. Sometimes you can increase the amount of energy up to 160 kcal per kilogram per day, but only if you also provide sufficient protein, because that actually forms your lean mass. So if you go up to the higher energy intakes, also ensure sufficient protein and of course all the other nutrients. So it's about keeping the balance, and you want to have an optimal protein energy ratio, and that amounts to approximately 2.8 to 3.6 gram of protein per 100 kcal, or in other words, 28 to 36 kilocalories per gram of protein that you supply. Talking about protein, the recommendation is to provide at least 3.5 to 4 grams of protein per kilogram per day in very preterm infants. And if the very preterm infant is growing not well, you may increase it up to 4.5 grams per kilogram per day, provided you also provide sufficient energy, for example, and other nutrients. There's no use of providing only proteins, but not providing the energy, so that because the proteins need to be used for growth, for anabolism, and that costs energy. So otherwise, if you don't provide sufficient energy to the proteins will be oxidized into urea, and that's of course a waste product. So during the higher intakes of proteins, you may want to monitor your plasma or your serum urea level as well. And if there is a high urea level, that is an indication that either your protein intake is too high, or you provide too little energy, or of course there are kidney problems or a fluid dehydration problem. Then if we move on to the next macronutrient, lipids, within ESPGHAN, we recommended that the total fat intake should be approximately 5 to 8 grams per kilogram per day, although sometimes it may be even higher. But I think usually 5 to 8 grams is okay. But lipids come in various forms, of course. I think it's always the best to provide long-chain triglycerides, but a small proportion of medium-chain triglycerides are acceptable, and they might even have some benefits as well. But please never give too much medium-chain triglycerides and keep the level below 40% of total fat intake. But it's also about, because these talking about long-chain triglycerides, these are the essential fatty acids, linoleic acid and linolenic acid. There are also numbers which can be found in the paper, and there's even now also recommendation on the long-chain polyunsaturated fatty acids. For example, fish oil, that's one of the long-chain polyunsaturated fatty acids, and those requirements within ESPGHAN, we is also recommended to increase them as well. I don't know about the formulas that are currently available in your country, but in Europe, there are also now increasing the amount of long-chain polyunsaturated fatty acids in formula products and also in breast milk fortifiers to fulfill to this demand. Because also in human milk, the level is usually not sufficient for preterm infants. That's why they need additional products. Then regarding the carbohydrates, the current recommendation is to provide approximately 11 to 15 grams per kilogram per day. And if you go above this 15 grams per kilogram per day, please check also the glucose level, because you are in the risk of going into hyperglycemia. I hope you still adhere with me. It's quite a list of all numbers and everything, but I think this presentation will be made available for you for later review as well. And as said, you can also find all the numbers in the paper and in the e-learning. With regard to electrolytes, I just shortly mentioned the numbers as well. We recommend now a sodium intake of approximately 3 to 8 millimole per kilogram per day, with the upper range is what the neonates may need when they are growing rapidly. So if you grow rapidly, just also provide sufficient sodium, because there might be a shortage. Fluoride is the same. And for potassium, we recommend an intake of 2.3 to 4.6 millimole per kilogram per day. And also the infants will grow the fastest, also, of course, need the highest intakes of potassium. Then the minerals, calcium, phosphate, and magnesium. We advise for a preterm infant to fortify the human milk with a multi-nutrient fortifier, which also includes phosphate. But if you don't have a breast milk fortifier available, maybe there are ways to provide phosphate and calcium as separate supplements, because preterm infants are very vulnerable to shortages of calcium and phosphate. The recommended intakes for calcium are 3 to 5 millimole per kilogram per day, and for phosphates, these are a little lower, approximately 2.5 to 3.5 millimole per kilogram per day. And for magnesium, the amounts are 0.5 millimole per kilogram per day. If these nutrients are provided in within artificial milk formula, you may need some higher intakes, because there is some malabsorption, especially for calcium, if it's in artificial formula when compared to human milk. So this was really dry material, all these numbers, but I think the next part of this presentation, in the final 10 to 15 minutes, I hope it's a little bit more lively and without all the numbers, because we come to more practical points of the ESPGHAN recommendations. So first, some background on growth. I think we all know that with nutrition, we want to influence neonatal growth and, of course, outcome. But in fact, it is a very complex interplay. Maybe nutrition has a direct effect on outcome, but it can also be that because you provide more nutrition, your growth is better, and because of better growth, this may result in a better outcome. But with nutrition, and especially human milk, of course, you can also prevent, hopefully, a disease to happen. And if there is less disease, then you also have less negative stimuli that contribute negatively to the outcome. So, and simultaneously, if you have an ill baby, it will probably not grow as well. So you have adverse growth, and if you don't grow well, we know that is not good for your outcome. So all these aspects influence each other. But ultimately, we want to improve the outcome for the infant. And in fact, when we look at outcome or developmental outcome, when we look at the brain, classically, we always thought that inflammation and sepsis and ischemia were bad to the brain, but probably one of the most common injuries to the brain of a preterm infant is not only inflammation and ischemia, but nutritional deprivation or suboptimal nutrition is also very harmful for the growing or for the preterm infant on the neonatal intensive care unit. And that's something which we can often influence the nutrition. Nutrition and growth are important, not just also for body growth, but as I said, also for the brain. And this is the transformation that the brains of a preterm infant undergo while the infant is lying on a neonatal intensive care unit. You see some pictures of a brain. On the upper part, you see real pictures of a fetus of approximately 20. This is the brain of a fetus of 20 weeks gestational age. Here you still see the smooth brain of an infant of about 25 weeks gestation, and here on the right side you see a well-grown walnut-shaped brain. Below are the images on the MRI, and you can really see the transformation that the brain undergoes while it is lying on a neonatal intensive care unit. And as said, with nutrition, we can really influence this all beneficially, but also not in the proper way. So what is necessary for healthy growth? Well, as said, you need, of course, nutrition, and the main driver of proper growth is, of course, protein of good quality, and especially the proteins in human milk are important, but also, as said, the energy to support that cost of protein synthesis. Also, you need the essential fatty acids, as I just said, and of course, you need all the micronutrients. And phosphate and calcium are important for this. Unfortunately, the amounts of calcium and phosphate in human milk is too little, so you need these also in your human milk fortifier or in your breast milk fortifier, so that calcium and phosphates are provided with that as well. You also, of course, need some oxygen because that is the driver for your metabolism. Not too much oxygen, but also not too little. You need the anabolic hormones that your body synthesizes, and it is good to know that in an inflammatory state, like for example a sepsis, the anabolic hormones are counteracted and you will not reach sufficient growth. It is very difficult for a critically ill infant to growth. So preventing an inflammatory state is absolutely crucial for growing stably on the intensive care units. So how do we do actually on the neonatal intensive care unit? Well, not too good. These are graphs and a table from some papers over the last 20 years. And actually, what is the main point of this is that the green line is the intrauterine growth, but what happens if a fetus is born? Then it no longer follows that green line, but on a NICU, most infants grow slower. Well, this was more than 25 years ago. This was about 10 years ago, a little bit better. And now a few years ago, these are the results from 6,000 preterm infants from a few years ago. It goes a little bit better, but still many infants lose some weight while they stay on intensive care units. Because of time, I'll go a little bit faster on this. But what do we advise within ESPGHAN? And you probably also know that appropriately grown, intrauterine appropriately grown neonates, they typically lose on the intensive care unit about 7 to 10% after birth. But after a week or so, or within 10 days, the birth weight should be regained, and you should stably follow the growth pattern from the growth curve. Small for gestational age infants, we thought historically we thought we should manage small for gestational age infants differently than appropriately grown infants, but in fact we should more and more follow the same approach. Some catch-up should be allowed, but rapid catch-up growth after growth faltering should be avoided. Of course, how to start enteral nutrition after birth? Well, minimal enteral feeding can be applied, and absolutely minimal enteral feeding is better than nothing by mouth. But in fact, we recommend to start immediately after birth with small volume enteral feeds and advance them as tolerated. So there's no use of keeping an infant, a preterm infant, for 3 days or so or even longer on minimal enteral feedings. No, our advice is also if the infant is respiratory unstable or so, start enteral nutrition ASAP after birth, and increment the daily volume with about 20 to 30 ml per kilogram per day, especially if you have human milk. Routine monitoring of gastric residuals in stable infants is not recommended. Only do gastric residuals in unstable infants. And of course, each NICU should have their feeding guidelines available to all the consultants and dietitians. Then to human milk. I just want to highlight that each mammal has its own milk, and of course the human milk is really adapted to also for preterm infant because it contains high carbs as a fuel for the brain, but also it's high in immunoactive proteins. That is of course what we want, because we know that human or mother's own milk has the best clinical effects in preterm infants. These are some older data, and what is shown is that there is a dose effect of the amount of mother's own milk as compared to formula feeding on the prevention of adverse effects such as necrotizing enterocolitis or sepsis. So here are two studies, and what you see, for example, in the study on the right, this is the proportion of human milk that's provided versus formula feeding, and you see that the infants who have 0 human milk, they have about a 15% chance of developing NEC or sepsis, while the infants who have more human milk, they have much less chance and better chances of survival without NEC. So each drop of human milk is very valuable. And that's also on the long term. Are these effects seen? This is from a very large French cohort where they looked at IQ score, so to say, at the age of 5 years on the graph on the right. And here are the infants who are on the left in this graph, who never received any mother's milk, but the more mother's milk was provided, even also after discharge, the higher the IQ of the formerly preterm infants was during follow-up. And this was all adjusted for many background variables. So that's why we also use donor human milk in preterm infants if their own mothers do not have sufficient milk, because we want to prevent the usage of formula in preterm infants. This is from a paper a few years ago where they were able to halve the amount of necrotizing enterocolitis if they provided donor milk if there was a shortage of mother's own milk. So that's why in Europe many donor human milk banks were founded, and also within ESPGHAN we recommend the use of donor milk over fortifier or over formula, if there is insufficient mother's own milk. But donor milk is not as good as mother's own milk, so always make the whole staff and the women support to express mother's own milk, because mother's own milk is even much better than donor milk. So that is the first priority. One other advantage of human milk is, of course, the colostrum, and it is probably a good idea to provide colostrum in the mouth, in the cheek of the preterm infant a few times a day. So during the first days of life, if the mother only has a few drops of colostrum, please collect it and put it directly in the mouth, in the cheek of the preterm infants, because it's full of immunoactive factors and it can really help prevent sepsis and other adverse events. I'm coming to the end of this presentation, but one statement about the fortifiers. within ESPGHAN, we think it's really important to use a fortifier for human milk, not only to provide protein or energy, but also to give that sufficient phosphate and calcium, because human milk for preterm infants is lacking those minerals. So take-home message: preterm infant or preterm birth is also a nutritional emergency. It's not only about the lungs and the heart, but it's also about nutrition in the gut. Well, nutrition is also in our hands. So as a doctor, we are also responsible for providing the optimal nutrition and help mothers express human milk. And hope by knowing this, you can also help improving the outcomes of your preterm infants. So finally here, this is again the QR of the e-learning. And as said, I will provide the link also in the chat. But I hope you will learn much more from the e-learning as well. And I'm happy to take any answers in the Q&A following this presentation. Thank you.
Thank you, Dr. Chris, for that presentation. It's been a very elaborate one. And you've just reminded us that growth faltering and malnutrition is unfortunately high in our NICU, and that the feeding of these babies are in our hands. We must do everything to make sure that they receive what is appropriate for them. You've also gone through the recommendations using the ESPGHAN recommendation, the fluid, the energy, the total fat, and even the electrolytes. And in terms of feeding practices, you talked about the use of a minimal enteral feed and starting as early as possible, not starving these babies for 3-4 days before feeding them, because preterm birth is also a nutritional emergency. You've also told us the rate at which we can advance, and you talked about the buccal colostrum, that we can start as early as possible. And you've gone to tell us about what to feed these babies with. The mom's own milk is the best. It's golden. And whenever we can grab it, we should use it, no matter how little, because even a little drop helps to prevent adverse events, including sepsis, necrotizing enterocolitis, and even overall survival. So both in the short term and in the long-term basis, breast milk is the best. When it's not available, you've also told us that we can use the donor milk for countries where they have it available. And lastly, when all these, when we cannot see the mom's own milk and we can't get donor milk, then the preterm formula will be what we are going to add. And you've told us about the importance of fortifiers for places where it's available. We indeed appreciate your very educative and interactive presentation. And I want to remind distinguished healthcare professionals that are here, if you have any question, please do type it in the chat Q&A. We'll, at the end, take all this and we move on. Thank you once again, Dr. Chris, even as we quickly
Thank you for your fantastic summary.
Thank you, thank you.
Fantastic.
Thank you. So we're going to move on to the second presentation. And I want to introduce my president, the president of the Nigerian Society of Neonatal Medicine, Dr. Maria Muktayola, who is a chief consultant pediatrician neonatologist that is practicing at the National Hospital, Abuja, Nigeria. She graduated from the University of Maiduguri in 1992. Where was I then? I was about to enter medical school with distinction in pediatrics and microbiology, and did postgraduate training at the Lagos University Teaching Hospital, both in Nigeria. She's a fellow of both West African College of Physicians and the National Postgraduate Medical College, and also holds a master's degree in public health from the University of Sheffield, UK. Dr. Muktayola has spent at least 30 years practicing in child health space, of which 20 were spent in newborn medicine. Special areas of interest include asphyxia, prematurity, and pediatric infectious disease, for which she received further training at Cincinnati Children's Hospital in Ohio and the Institute of Human Virology, Baltimore, USA, as well as Sheffield Children's Hospital in the UK, respectively. Dr. Yola publications have appeared widely in peer-reviewed articles in local and international journals, as she has contributed to several national guidelines, technical reports in peer-reviewed articles in technical reports on child health, and even textbooks. Currently, she is my president, the president of Nigerian Society of Neonatal Medicine, as well as member of several local and international professional associations. So Dr. Mukhtar Yola will be taking us through the guideline of the feeding of the sick and small newborn, the Nigerian context. Over, ma.
Thank you so much, Professor Ilo, for that kind presentation of a brief resume. I want to thank the organizers for making this event possible. And I want to congratulate Dr. Chris for that brilliant presentation. My role this afternoon is to add a local content to the subject matter, okay? And I'll be talking about especially bringing out what is in our Nigerian national guideline on the feeding of the small and sick newborn. So by the end of this session, we'll learn more about the feeding of the small and sick newborn. We'll learn about the value of donor milk and challenges of breast milk banking in our local environment, and how do we locally fortify breast milk in the absence of human milk fortifiers. We already know that adequate nutrition is essential for optimal growth, development, and long-term health for newborns, particularly the very low birth weight babies and the sick newborns. And nutrition can be delivered both enterally and parenterally. And there's no doubt about it that breast milk is the preferred choice because it has antibodies, anti-infective factors, as well as nutritional components. Nigeria is predominantly a breastfeeding nation. However, our exclusive breastfeeding rate is still low. So colostrum, that yellow golden milk, I always love to talk about it because in my culture, there's a lot of misconception about the colostrum. A lot of mothers extract it and discard it, thinking that it's dirty milk. But we know that it is gold wrapped in a drop because it is rich in antibodies. It has many white cells to prevent infection. It has positive properties which can help to get rid of the meconium, and it's rich in growth factors and important vitamins such as vitamin A. Okay, it can help to reduce jaundice because of it clearing the meconium, and also reduces the severity of some infections such as measles and diarrhea. So I'll be talking to us about guide from the Nigerian guideline on comprehensive newborn care. The following determines how a low birth weight or preterm infant should be fed. The birth weight of the baby is very important. The gestational age, the presence or absence of sickness, and the individual feeding efforts of the baby. The gestational age is definitely one of the most important determinants, as coordinated sucking and swallowing does not develop until around 34 weeks of gestation. How much breast milk should we give according to the birth weight and the age of the baby? There's a general guide for birth weights between 2,000 and less than 2,500 grams, which is approximately between 33 and 34 weeks. If the baby can suckle directly on the breast milk, we should allow the baby to do so. If she cannot, then we should express the breast milk and use an alternative feeding method, such as cup feeding. But for smaller babies, between 30 and 32 weeks, usually the coordination between sucking and swallowing is not adequate. So we should use alternative feeding methods every 2 to 3 hours until breast milk can be taken directly. What about the smaller babies? The smaller babies less than 1.5 kg, it is recommended that we commence buccal colostrum swabbing within the first 6 hours of life. Chris has told us how to do it. Just a drop or two within the cheek of the baby is going to do magic in terms of infection prevention. Thereafter, we commence minimal enteral nutrition or trophic feeds, usually to prime the guts within 24 hours at maybe about 10 mils per kg per day. How do we time the feeds? For the smaller babies, less than 1,500 grams, it's best we feed them every 2 hours. But for the babies that are bigger than that, every 3 hours would do. However, in order to promote lactation and to enable the baby to learn to suck, all babies more than 1,500 grams should be put to breast for at least 5 to 10 minutes before cup or tube feeding. That's very important. How do we advance the feeds? Usually we increase in 20 to 30 mils per kg per day with the aim to reach full enteral feeds. That's about 150 to 180 mils per kg per day within 7 days in babies that are stable and more than 1,500 grams, or within 10 days in babies that are smaller. The aim is to provide calories between 120 and 150 per kg per day. This is just a chart showing possible routes of feeding according to gestational age. So when a baby is well fed, the best way to know is by monitoring the weight, or if the baby is not well fed, weight is usually a good guide. We know that preterms would lose about 10 to 15% of their body weight physiologically within the first 7 to 10 days. However, by the second week of life, these babies should regain their birth weight. Normally, they gain between 15 and 20 grams per kg per day. Any baby that is gaining less than 10 grams per kg per day must be reassessed. So we are recommending early feeding for these babies, but are there any contraindications to early feeding? Yes, babies that are very ill, for instance, babies that have had severe birth asphyxia, we may not start feeding for fear of guts injury. Babies that are having frequent apneas or bradycardia, those with overwhelming sepsis, necrotizing enterocolitis, etc., these babies should not be fed immediately because more harm can be done rather than the good. So we hold on until they stabilize a little. So regarding the sick newborn, how do we feed the sick newborn? We know that sometimes they're too ill, they cannot even take the cup and spoon. So such babies, we can feed them using the nasogastric or the orogastric tube. Those that can coordinate sucking, we can use the cup and spoon, or we can use a syringe, or alternatively, we can even use a continuous milk drip, which would deliver in very minute contents. However, whenever we're doing cup feeding, we must be sure that hand hygiene is practiced and we use clean and safe utensils. To express breast milk, there are multiple ways of doing it, and this is a valuable practice because the mother can be away from home and breastfeeding can continue. Expressed breast milk is good at room temperature. It can stay up to 6 hours. And if you put it in the fridge, it can stay up to 24 hours and it can be frozen for 3 to 6 months. So breast milk can stay a long time if looked after carefully. Expression can be manual or using a pump. This is just a picture showing what the nifty cup looks like when you want to feed a baby with a cup. It's an example of a cup feeding method. There are several types of cups. These are some examples, but there are also very many local devices depending on the environment you live. This is showing how to insert an NG tube. You usually would like to measure between the nose, the lower lobe of the ear, and a midpoint between the xiphisternum and the umbilical cord to pass a nasogastric tube for feeding. This is also another method of tube feeding. We can use the syringe and remove the plunger and allow the feeds to go down by gravity. Usually by the time you're raising the syringe higher up, the milk tends to go down, and you can regulate the flow so that you don't rush in the feeds for the baby. Very useful in small babies. So how do you transition to direct breastfeeding? This should be commenced as early as the baby is ready. Usually from 32 weeks, some 34 weeks, they're able to cope. Breastfeeding babies may be introduced straight from NG tube to breastfeed. However, we must make sure that the baby has an intact suck and gag reflex and must have reached the full volume of NG tubes. We introduce the feeds gradually, maybe 1 or 2 feeds per day, and then express breast milk should be provided in between. We should assist the mother to ensure that she maintains sufficient milk production. So the sick newborns, those that cannot feed immediately, are usually started on intravenous fluids. However, it is still encouraged to give them buccal colostrum. The fluid volume and content are usually dependent on the gestational age, the postnatal age, and the clinical status. Usually we start with dextrose-containing solution on the first day, and then electrolytes are introduced on the second or third day. If we have parenteral nutrition available, it can be started usually on the second day. Oral feeds are then gradually introduced as the baby is able to tolerate. There are several indications for intravenous alternative parenteral feeding. They could be medical or surgical. The very low birth weight babies or the preterm babies prior to full enteral feeding qualify. Babies in severe respiratory distress or those that have recurrent apneas and you're afraid that they may aspirate also qualify. Babies that have frequent convulsions or cardiorespiratory instability, or babies that have bile-stained gastric fluid or signs of feeding intolerance. This can be started. Other surgical indications could include gastrointestinal obstruction, necrotizing enterocolitis, TOF, and bowel obstruction. So, which IV fluid do you use? In our environment, we have a lot of challenges, and that's why this is important. The choice and volume of fluid would actually depend on the age of the newborn. Usually 10% dextrose water without electrolyte is used in the first 24 to 48 hours of life until adequate kidney function is established. However, in smaller babies, 5% dextrose may be the best fluid of choice because of the risk of hyperglycemia. However, within the first 24 to 48 hours, we usually aim to give 80 to 90 mils per kg for preterms and 60 to 70 mils per kg in term babies. And we increase this by 10 to 20 per kg per day. We can adjust the glucose concentration as the volume increases to maintain a GIR of 6 to 8 milligrams per kg per minute. If the baby is under phototherapy or radiant warmer, especially in our own environment, which is hot and humid, we usually add an extra 10 to 20 mils per kg per day. Babies, however, that are asphyxiated or have HIE, we tend to reduce the amount of fluids we give them for fear of SIADH until urine output is clearly established. Beyond 24 hours, if the urine output is well established, we can add maintenance electrolytes such as sodium, chloride, or potassium. In babies at risk of hypocalcemia, calcium is recommended, especially preterm babies and babies with asphyxia. When constituting IV fluids, use the least number of constituents to supply required electrolytes to minimize the risk of contamination. Okay, if the baby receives any other intravenous fluid, such as blood or fresh frozen plasma, we must remember to deduct from the calculated IV fluid. How do we deliver this? Okay, there's what we call the drop factor. You can use a Soluset. We can use a Soluset usually gives 60 drops to 1 ml. A blood giving set gives 15 ml to 1 ml, while an infusion set gives 20 ml to 1 ml. Okay, and this is how to calculate the flow rate. So depending on what you have in your environment, if you have a syringe pump or an infusion pump, life is much easier for you. But if you don't, then that is a good guide on how to deliver the fluids. In terms of monitoring, it's very important. We must maintain strict asepsis during fluid constitution. We should change the solicet if we're using a solicet every 48 hours, and make sure that fluids are freshly constituted daily. And if we see any change in color, we must discard that fluid. We must never add calcium to fluids that contain bicarbonate, and we must check the fluid flow rates hourly and make sure it is charted. Also inspect the IV line site every time and check for swellings or redness. Always ensure that you monitor the urine output and document it. Okay, we must weigh daily and check the clinical signs, respiratory rate and heart rate, document the fluid balance daily, and correct any deficits promptly. We must not rush deficits rapidly because these babies cannot tolerate large volumes at a go. We must monitor the sugar and electrolytes. I think this has been covered by Chris, so we can skip this slide. So caloric requirements, we usually need calories for energy expenditure and for growth. The growth rates are similar to those achieved in utero, between 14 and 20 grams per kg per day. It can be sustained in preterm infants with an additional parenteral intake of about 70 kilocalories per kg per day to achieve growth. There are several indications for parenteral nutrition. Very small babies, less than 1.5 kg, that cannot advance enteral nutrition early. Parenteral nutrition is recommended. Or babies that are not expected to tolerate infant oral feeds for more than 3 days, it is recommended we start with parenteral nutrition. If you have a patient with suspected neck or confirmed neck, or babies with post-surgical complications, or with gastrointestinal anomalies, or an infant that is failing to gain weight, even on enteral feeds, can have a complementary parenteral nutrition. We're very familiar with the components, the fluid volume, the calories, glucose, protein, lipids, vitamins, minerals, and additives. Now, let's talk about the human milk and the small and sick newborn. We know that the particular composition of human milk at that gestational age makes it suitable for nutritional and biologic requirements of that particular baby. Breastfeeding, with only a few exceptions, is the norm in infant nutrition, conferring short and long-term health benefits. It is essential for very low birth weight infants, primarily during the first critical weeks of life. And it has been shown that human milk feeding in this group of tiny infants improves both short and long-term health outcomes and decreases mortality rates. They tend to be protected against necrotizing enterocolitis, sepsis, retinopathy of prematurity, BPD, while having better neurodevelopment and cardiovascular health outcomes in the long term. The World Health Organization, UNICEF, American Academy of Pediatrics, and ESPGHAN have clearly recommended a guide on breastfeeding, because it is stated that infants who cannot be fed their own milk or who need to be supplemented, especially the very low birth weight infants, should be fed donor human milk. Okay, donor human milk is strongly recommended if mother's own milk is not available. Mom is the first choice for all neonates, yet many tiny babies are unable to get that. When it is not available or insufficient, then we should use donor human milk. Although some bioactive milk components are lost to varying degrees with the heat treatment methods widely used by milk banks, many other precious bioactive compounds are completely or partially preserved that are not found in preterm formulas. So let's talk about human milk bank. This may sound so natural and so easy for those living in foreign lands, but in Africa, we do not have human milk banks readily available. Of restarting this process. So human milk bank is a facility that selects, collects, screens, processes, stores, and distributes human milk. Okay, to establish a human breast milk bank, you need a couple of criteria. You need the staff that are dedicated and appropriately trained to deliver the workload. You need the devices. The minimal equipment is at least one pasteurizer, a freezer that keeps at -20 degrees with acoustic and visual alarms for temperature changes. We need a refrigerator. You need, with minimal cooling and maximum temperatures, you need a workstation and electric milk pumps covering the needs of the donor. And if mono-use bottles are not being used, you need a dishwasher with thermos disinfection and a system hermetic closure of the bottles. So apart from staff and devices, we also need to have a good location. You know, a human milk bank should be functionally associated with at least one neonatology unit that is responsible for the care of preterm infants younger than 34 weeks. The space is very important because it should be structured in such a way that it permits an effective control of the activity and a thorough cleaning and disinfection. There are evolving breast milk banks in some states now in Nigeria, notably in Lagos and Abuja. They're making strides to fill in the gaps. As I mentioned before HIV, we had several milk banks, but all of them closed. But the practice is now coming back. However, this is not without its own challenges. The challenges include community challenges. There's low acceptance in our community of donor human milk due to safety concerns. Some people think it's not safe due to risk of disease transmission and the quality of donated milk. Some people just have personal preferences. How can I give my baby another person's milk? So it's that aspect of it. There's also the religious aspect, religious stigma and cultural beliefs regarding the transfer of hereditary traits and decrease in the mother-child affection that acts as barriers in donating milk. We also have the system challenges due to poor funding, lack of dedicated technicians. We also have to battle with unstable manpower and things like that. So there are a lot of challenges that need to be sorted out. So human milk fortifiers are, but they're not readily available or accessible in our country. Cost is also a rate limiting step. If a baby is not thriving adequately on mother's own milk. There have been several the use of medium and long oil or soy oil added to breast milk is practiced in some. Usually you take like 1 ml of soya-based oil and dilute it with 24 ml of breast milk. 25 ml solution, and that can be used for feeding because one gram of oils or fat can give you about 9 calories of fat. Others also just sprinkle a little formula into the breast milk to increase the caloric density. So in summary, we have discussed that nutrients can be delivered via the enteral and parenteral routes. IV fluid ensures that newborns receive the necessary daily fluid, some calories, electrolytes, and micronutrients while aiming at full enteral feeds. Most sick newborns and very low birth weight babies will need to be commenced on intravenous fluids from day 1 of life, or parenteral nutrition, and also if there's a contraindication to enteral feeding. We must note that development of bloodstream infections through IV fluid can be a complication if asepsis is not adequately practiced. I think this summarizes what we have discussed this afternoon, and I thank you so much for your rapt attention. Over to the moderator.
Thank you very much for this lucid presentation. It's been quite interesting. In fact, I've been glued to my seat since you started. Thank you very much. And thank you for bringing out the Nigerian context, at least giving us a guide from our national guideline on comprehensive newborn care. It's been a wonderful presentation. We are grateful for the time that you've spent. And one of the things that came out from your presentation is the issue of gestational age being one of the most important determinants of how to feed these babies, especially bearing in mind that these babies do not start the coordination between sucking and swallowing until they are up to 34 weeks. So we must be very careful when we are feeding them. And you've also told us that mom's own milk is the best for us to start with. And we must at all times pursue the colostrum, the golden milk, being the first antibiotics that these babies will get, even if it means rubbing it on their mouth, on the buccal mucosa. That's very important and beneficial for this baby, both in the long term and also in the short term. We're really very grateful for your time. You've also looked at the challenges we are having with having our own donor milk bank in Nigeria. We started before HIV and all that, and also how we can locally fortify our own breast milk. I wish that someday there will be a paper that will come out from what people are doing in different centers. I tell you, we are doing so much that we need to document this for the world to see what we are doing. We're quite grateful for your time and the effort you've put into this presentation. So now we're going to be taking our Q&A. Please, if you've not typed yours, I've been seeing wonderful presentation, insightful presentation, and all that. Thank you for all your kind comments. But we also need questions. So let me go to the Q&A section and see what we have. Chris, are you still with us?
Absolutely, I am.
Okay, so I can see that most of the questions you've actually answered, but it would be
but
nice.
We can discuss them still.
Yes, exactly. So if you can take a few of them and just discuss on them to give us more insight. Thank you.
So you want me to replicate some of the questions of the Q&A?
Yeah, okay. That's okay. Just a few of them. Yeah, okay. That's all right. Go ahead.
Well, thank you also for this wonderful presentation that Dr. Maria gave. Absolutely fabulous and really learningful. And I think we have a good overlap, so that's really nice to hear, despite we also live in different parts of the world. But really, yeah, fantastic to hear. Well, one of the questions also just covered were, for example, how can buccal colostrum prevent necrotizing enterocolitis? I think it's really important because, as already told, colostrum is full of immunoprotective factors, and it will really stimulate all gut hormones and gut trophic factors, which will stimulate the development of the gut. And ultimately, that might prevent necrotizing enterocolitis. But there's also an additional aspect of stimulating buccal colostrum, and that is more of a psychological effect, because if you involve the mothers, and both parents actually, but the mothers who provide colostrum so early, you really involve them in the care, and you give them a really important role, and that will hopefully stimulate the women also to continue expressing more milk which will ultimately, hopefully, also result in more human milk availability by that woman. So I think there are two effects: a direct immunological effect, but also the psychological effect of involving the mothers. I think that's also really important. I think also other things have been involved or discussed already. The main risk factors for necrotizing enterocolitis. I think we've said buccal colostrum, mother's all milk is very important. But also avoiding too much antibiotics is also important. Infants who have had several weeks of antibiotics, they are more vulnerable for necrotizing enterocolitis, because necrotizing enterocolitis is also may also occur after a disturbed microbiome. So all the good bacteria in the gut are also eliminated after antibiotics. And it is known that each additional day of antibiotics increases the risk of developing subsequent necrotizing enterocolitis. So if you can avoid antibiotics, do so ASAP, but of course, sometimes you need antibiotics. So it's a delicate balance. Also, some probiotics that luckily we have the availability since 2 years to start certain probiotics as well. And we are really happy with having the opportunity to have probiotics. And for us, it gave also a decrease in the amount of probiotics. I don't know, maybe there are some other questions. Also, if you don't have a fortifier, can you, to the human milk, can you add some formula milk in the human milk as an alternative for the fortifier? Well, there have been studies practicing this approach. I also provided a link to the paper in the article who did this. You will not get the same composition because the fortifier is much higher in protein relatively, and more calcium and phosphate than in formula. But if you don't have any fortifier available, and I think it's an acceptable approach to add a bit of formula in the milk. And of course, you can also increase the amount of milk if the infant tolerates up to 200 ml per kilogram per day, and maybe add a little bit of calcium and phosphates, separate supplements if you have those. That could be an approach as well. But yes, formula is also acceptable.
Yeah, thank you, Chris, for that, for the answers given and the explanations given on the questions that were raised in the Q&A chat. And there was one of the questions which you had actually answered that is quite insightful. Somebody had asked the preterm formula and necrotizing enterocolitis. And you quickly say that it's better you don't starve these babies. So if you're going to use preterm, if you've done everything to get the mom's own milk and donor milk and you can't get it, the preterm formula can be started. But you talked about being very cautious. The volume you're starting and then the increment, the advancement should be a cautious one, because these babies should not be starved because you are afraid of necrotizing enterocolitis. Thank you for that answer. I just wanted to bring it out for us to see. Please, we can also read the answers given at the Q&A box. There are lots of them, very insightful answers. I want to call on Dr. Maria to take on some of the questions that came up from her presentation too. We are really running out of time. Maria, over to you.
Okay, I'll quickly respond to some of the questions. I saw a lot of interest of the presentation, and mainly they're related to concern about screening. How are we able to make sure that the donor milk has been screened, and how? So, and I think I mentioned this as one of the biggest challenges we have. Starting up a donor milk bank is not a cheap thing. It's not an easy thing. You have to be ready. You have to have the required staff. You have to have trained staff, not just staff, trained staff. You need to have the required equipment. So usually part of the procedure is that the milk is treated, and then it is screened for at least hepatitis B, hepatitis C, HIV in more sophisticated centers, and a host of other things depending on the center where the practice is done. So as long as the whole process, it should be safe. Okay, it is not, of course, good as mom's breast milk, but it is the next best thing. Actually promoting the use of donor breast milk banks, but we need support that would help us set up a proper breast milk bank so that especially the small and sick newborns, they can benefit from it. It's one in Abuja, one in Lagos, and it's worthwhile because we're talking about saving lives. 3 questions all related to safety of donor breast milk bank. In centers that do it, you saw the map that Chris showed us. Netherlands is one of the, Europe in particular, is very rich with that practice of donor breast milk banks. So they have a lot of experience with it. Maybe the next presentation should actually get someone from that angle to share their information with us so that we can learn about best practices. I hope that answers the questions, Professor Taylor.
Yes, of course. Thank you very much for that response to the answers. So we're going to move on now and round off in the next few minutes.
All right. Thank you so much, everyone, for your rapt and your kind participation in this webinar. You agree with me that this was really impactful and also full of knowledge. And that's why at the end of this, please complete the post-webinar evaluation, especially for those who would like to receive certificate for this webinar, and also for the Nigerian participant audience that will need data reimbursement. We also look forward to having you back in our June edition of our webinar, where we'll be looking at lactose and lactose intolerance. So with that, just want to notify that FrieslandCampina Institute also have some other e-learnings, like for instance, we have for nutrition and healthcare professionals, we have 5 modules that are very easy to go through. We have them in a downloadable PDF format where you can just download, go through them, and answer the question, after which you can get certificate for attending. And to have access to this particular e-learning, you just have to go to www.FrieslandCampinaInstitute.com/e-learnings. There you will see all the free e-learning materials there. And please, for us to have your details for those that would like to get a certificate, please just scan this QR code or the link that will be dropped in the chats, or you can just scan the QR code to have access to where you can put down your informations, especially for those that would like to receive certificate of attendance, and also for the Nigerian participant that will require data reimbursement. And with that, I just want to say a very big thank you all for your time. And we do apologize for exceeding the 3 o'clock stoppage time. And with that, I say thank you, and I look forward to connecting with you some other time shortly. Thank you all, and do enjoy the rest of your day.